Now that we've discussed the treatments for benign hyperbilirubinemia, now let's talk about the treatments for severe hyperbilirubinemia. And now, here's where it gets interesting. We talk about phototherapy, those blue and white lights you see whenever you go to a neonatal incubation unit, and also you'll have exchange transfusion, in which they exchange the plasma of the baby with regular plasma to remove all of the unconjugated bilirubin. So let's start talking about these. First is phototherapy. Phototherapy is only used for unconjugated hyperbilirubinemia. The way phototherapy works is that it converts the lipid-soluble unconjugated bilirubin into water-soluble metabolites so they can be excreted. This wouldn't be necessary for conjugated hyperbilirubinemia because the conjugated bilirubin can just be removed by the kidneys anyway because conjugated bilirubin is water-soluble. So conjugated hyperbilirubinemia does not require treatment with phototherapy or with exchange transfusion. So some indications for phototherapy. As you can see, white light is for maintenance and blue light for intense. So if you have a very severe symptomatic infant, you can give them blue light therapy with exchange transfusion, but exchange transfusion is more important. And for mild hyperbilirubinemia that meets these indications, you can give white light phototherapy. So let's look at the indications. Total serum bilirubin greater than 18 milligrams per deciliter. So that's our magic number here. So if it's greater than 18, you should be considering phototherapy. And this is for a term infant. For preterm infants, you can see, you can initiate phototherapy at lower levels than if symptomatic. So this 18 is only for term healthy infants, and if it's preterm and unhealthy, symptomatic, you might have to give phototherapy earlier. So here are some numbers you don't have to memorize, but it's good to know that a term infant, when the unconjugated bilirubin is greater than 15 between days 1 and 2, or 18 between days 2 and 3, or 20 after day 4, or after the end of day 3, you should be concerned about a severe hyperbilirubinemia and give phototherapy for these patients. So very important to know, and you don't need to treat conjugated hyperbilirubinemia. It's not as urgent because you can't get kernicterus from conjugated hyperbilirubinemia. Now let's talk about exchange transfusion. This as well is only for unconjugated hyperbilirubinemia because you have to get rid of the unconjugated bilirubin, which cannot be excreted by the body. Remember, lipid-soluble substances are very difficult to excrete. Only way you can excrete them is through the bile, and the pathway for unconjugated bilirubin needs to go through the UDP glucuronidinotransferase. So we have a problem, and if we have a buildup of unconjugated bilirubin, and it's a very severe symptomatic infant, we need exchange transfusion. So it's an emergency measure that via plasma exchange, so you're taking plasma from the baby and replacing it with normal plasma, you remove unconjugated bilirubin from the circulation. So you're removing the unconjugated bilirubin, and it's always if the bilirubin is greater than 25 milligrams per deciliter. Okay? Indications are for term infants, and these are for term infants that have a serum bilirubin greater than 20 at between days 1 and 2, or more than 25 at greater than 48 hours. The main thing you want to remember is 25 milligrams per deciliter at any time. If the bilirubin is that high, unconjugated, it's a very severe problem, and it can have a high risk of kernicterus. So you need to do something to protect the infant's brain. So the preterm infants will receive exchange transfusions at lower serum bilirubin levels. So that makes sense. The more premature they are, the more immature their blood-brain barrier, the more immature their UDP glucuronidinotransferase. So you need to treat them much faster and much more aggressively to prevent kernicterus. So another indication is you have failure of phototherapy to decrease the levels of unconjugated bilirubin. So if phototherapy fails, then you can give exchange transfusion as a second-line treatment. Or if you have kernicterus symptoms and signs, you need to worry about severe problems and you need to give exchange transfusion. So if you have an option and the bilirubin is greater than 25, you have to give exchange transfusion over phototherapy. You can give phototherapy with it, but on the exam, choose exchange transfusion if you have a severe symptomatic infant or if the unconjugated bilirubin is greater than 25. All right. Blue light intensive therapy, as we mentioned before, can be used to acutely lower unconjugated bilirubin levels while preparing for exchange transfusion. But for the USMLE purposes, if they give you a very severe infant that has risk factors for kernicterus and very high bilirubin levels, choose exchange transfusion as your number one treatment. All right, that's very important to know. And that was the theme of our first question all the way back in the beginning of the presentation. So now breastfeeding. I want to do a quick slide on breastfeeding to give you a good idea of how important this is and some contraindications to it as well. Remember that the number one source of nutrition for the infant, better than any formula, is natural breast milk. So always prioritize this whenever you have a neonatal jaundice condition. If the question stem has a neonatal jaundice and one of the answer choices says stop breastfeeding, you should carefully consider whether this will actually be beneficial to the infant. We've talked about some situations of these before. So you can pause breastfeeding temporarily, especially if the patient and the baby are not breastfeeding properly, but it needs to be restarted as soon as possible so the baby can grow and have a proper immune function. Breast milk is high in IgA, and that's very important for neonatal mucosal immunity, so it helps the neonate survive and fight off infections easier. Now some contraindications of breastfeeding. These are super important to know so you know when not to recommend breastfeeding for a mother. So some of these are active HIV infection. All right, if you have HIV at all, you need to give formula, unless you're in a third world country, but don't worry too much about that. In a first world country like the US, any HIV infection, you cannot give breastfeeding as a potential answer choice. No breastfeeding allowed. Active herpes breast lesions, so obviously you don't want to give the baby herpes, so you don't give breastfeeding there. Varicella 5 days prior and 2 days after delivery. So you have this 1 week window. If they have varicella during that time, you cannot recommend breastfeeding until the varicella has been completed and cleared its course. Okay? It's cleared and completed its course through the mother. And otherwise, you have to give formula in the meantime. Also, active TB. TB can also be spread through the breast milk, so you want to avoid breastfeeding during the active TB. Maternal substance abuse, because if you take drugs can end up in the breast milk and damage the baby. But supervised methadone, if they're going to a methadone clinic and getting supervised treatment, they can breastfeed in that condition. And infant galactosemia. Remember, galactosemia is a problem with lactose metabolism. What is breast milk going to have in it? Of course, lactose. It's milk. So it's going to cause a lot of severe problems in the baby. One last thing to note is that, do you notice that hepatitis is not here? Yes, hepatitis B, hepatitis C, any form of active hepatitis, breastfeeding you can still recommend to a mother. So hepatitis is not a contraindication to breastfeeding. Now, last rapid memory slide. So the stuff we've learned in the last 3 slides on severe hyperbilirubinemia and breastfeeding, write down everything you remember, and this will help you consolidate your memory. And thank you for completing this presentation. We'll have another one up shortly.